What's up, y'all? This is Carolina Doc PT, and today's video we're going to be talking about something that I've been getting some comments on recently, and I thought that it would be a good idea to do a video specifically based on that, and that is for you folks that have experienced knee replacement, and that has to do with physical therapist actually pushing on a patient's knee in order to achieve improved knee flexion. Okay, so what are my comments on that? I so okay. First off, let me say I am not meaning to criticize other physical therapists in their practice. Okay, if I was them and seeing you at the same point that they were seeing you, perhaps I would have made a similar decision and performed a similar treatment. Okay. So that's first right off the bat. I don't want to criticize other physical therapists when I haven't, experienced what, they experienced. Um, Second thing. So it is not wrong per se for your physical therapist to do this. Okay. We are in the plan of care of physical therapy treatments is manual therapy, doing some passive range of motion, doing active assistive range of motion where you are actually trying to bend your knee yourself, and then the physical therapist applies a little bit of overpressure behind that. All of these things are within the acceptable plan of care for a physical therapist. Okay. So any physical therapist that is, pushing on your knee or shoving on your knee, that is not wrong per se for them to be doing. Okay. So let's start off with those two things as our premise. All right. The the question, would I do that? No. I hate hearing the comment from patients, and having had some patients myself and experiences, with patients that I've seen where they talk about their physical therapist just pushing on their knee to try to gain flexion that is a challenge for them to get a hold of. Um, I don't like it. I don't think, technically, I don't think it should be done. Okay. I maybe there was once when I was doing some active overpressure, maybe, but even then, that's not. I mean, I've had some patients who were, say, stuck in full extension or close to full extension. I've had patients where they were stuck almost in flexion. Neither of those patients would I want to do that with. Okay. I think that doing that form of manual therapy, excuse me, treatment for your patient is more a treatment of last resort. Okay. If the next step is a surgical manipulation by that patient's surgeon, I can understand where a physical therapist might be led into thinking that, okay, this is what we need to do to try to get more or improved knee flexion on this patient's knee. I can understand that. My problem with doing that form of manual therapy for your patient is it is impossible to tell when you are grossly forcing someone's knee to bend when it doesn't want to bend. It's impossible to tell what you're actually affecting. Where is that improved flexion coming from? It, I don't like it because of that. It's too non-specific. I think it winds up leading to increased pain for the patient, certainly in the moment that you're doing it, but then also afterwards. You don't think that's gonna, you've just forced an issue to break through supposed scar tissue and stuff. So you don't think that's going to increase inflammation significantly now in that person's knee, and lead to significantly more pain. When they have more pain, are they going to want to do more exercises? Are they going to want to come back to see you? The answer to that is probably no. So I would only consider doing that as a method of last resort after I have done weeks and weeks and weeks of additional therapies trying to get that knee to move. Okay. Um, so in in place of that, where I think have had a lot of success, where I've seen a lot of success, is really doing manual therapy. But one, and this all needs to happen early on, really, um, is making sure that kneecap is floating. So for that physical therapist to do patellar modes is what they're called, where you're just trying to basically move that kneecap around. You're wanting to make sure it can go side to side and up and down. Your kneecap is free floating on your knee. A lot of people don't really realize that, and it moves as you are straightening and bending your knee. Your kneecap is actually, floating up and down, and that's what's helping to get that motion. Um, so you want to, one, make sure that kneecap is not being adhered to anything. Sometimes you can develop scar tissue underneath the kneecap if you don't really work on it very much, and then it can actually kind of stick to the whole situation. So if you start early on doing some gentle moves of the knee and making sure that kneecap is going, so that's what the PT, if they're like kind of fiddling with your kneecap for 5 or 10 minutes. That's what they're doing, is just trying to make sure that kneecap, that your patella can stay free floating there, and is making sure that it's able to move a little bit. So another thing that your physical therapist can do to help with your knee range of motion when it's becoming difficult is doing myofascial work and doing a release on your quadricep and your hamstring. So if your hamstring is really tight, then it's going to be difficult for you to fully straighten and fully extend your knee, because your hamstring is what contracts. The hamstring is the muscle that's on the back of your leg. It's on the back of your thigh. When you contract that, your knee bends and your ankle, comes up towards your behind. So that's the flexion. So if you're so that's what the hamstring is doing. If your hamstring is tight, then it's going to be difficult to fully straighten your knee and to fully extend your knee. So if you're having problems with extension, then you're going to want to manipulate and work on myofascial work to try to release the muscle of the hamstring. And it conversely, for your quadricep, this is the muscle that's on the front of your thigh. This is the muscle that actually does straighten your knee. So if you're kicking your foot out, then that's what your quadricep is doing. And if your quadricep is really tight, then it's not wanting to assist with letting, or excuse me, if it's really tight, then it's going to be hard to bend your knee. So your quadriceps and your hamstrings, they do kind of opposite motions. So if your quadriceps really tight, then it's harder to get that knee to actually bend. So those patients that are having difficulty with flexion, then what they can benefit from is myofascial work along that quadricep, because the quadricep can be a big culprit of that. And I mean, I can think of patients where we gained 15 degrees of flexion within a visit just by working that quadricep and doing myofascial work to release the quadricep. Now, is that myofascial work? Can that be painful in and of itself? Yes, it can. Can it bruise? Yes, it can. But it can also be very, very beneficial, I found, in treating muscles that have gotten, stuck maybe with scar tissue themselves. You can have kind of microscopic at or at the microscopic level, you can have bits of scar tissue build up, and then that prevents restriction. And if the muscle can't move and slide, then your knee is not going to be able to fully go through its work that you're trying to do and get a full extension, get to that zero that we're trying to get you to achieve most importantly, and then trying to get you to flexion that is generally at least above 120, if not significantly more, 130, 140. So for so there are other things, is my point. There are other ways that the physical therapist can do manual therapy with you and achieve these similar results. We haven't even discussed dry needling, which is something that is, I think, great to do. That can also help. Sometimes it may be that there are inhibitory factors going on because of pain that are preventing your muscle from actually moving. So if you can get the nerves to calm down with some dry needling, then that's makes it also a little bit easier to release. So that's another type of manual therapy treatment that can be done to assist in improving your range of motion. Um, so there are a physical therapist that is skilled should have multiple tools in their toolbox that they can bring out to try to work with you on achieving your range of motion goals after having had a knee replacement. And there are several that they should be able to utilize long before, and that can have success long before ever needing to start shoving on your knee and trying to get it to bend or straighten. That is and should be a method of last resort. Students that I've worked with, I always, tell them, and that's, I mean, really and truly, that's frowned upon. I would say I wouldn't do that. It's not my, that again, method of last resort. And even then, I would say you're probably better off having the surgeon just go ahead and do the manipulation, because those can be beneficial. Nobody wants to have another surgery. And so, we don't want to go through the additional cost of that, the additional risk of that. Anytime you're put under in us for surgery, there's always a potential risk. And so if we can avoid that surgery, we would do that. But those are the things that I would think about for your physical therapist to be doing manually before ever getting to that point. Also, right now, and with everything I've discussed or that we've talked about, we're only talking about the physical therapist doing this. I haven't mentioned word one about the exercise that you yourself should be doing. I mean, I've done several other videos on this, but there is no substitute for you working your knee and working on range of motion early on, like immediately, really, as soon as you wake up from your surgery. Your acute care physical therapist should be working with you on working and bending that knee. When you go into home health physical therapy, that home health physical therapist, that's their primary goal, is they're just trying to get your range of motion to improve. When you go into your outpatient physical therapist, they're the ones that are continuing to help progress that. All along, each step of the way, this requires you to do all of those heel slides, quad sets, the short arc quads, building into long arc quads, all those types of exercise. Those are the things that you're using to help improve that knee range of motion. So it all will work together. It all kind of blends together. That's why you can't do just one or the other. If you only are relying on the physical therapist when you go there and doing manual therapy, you are not likely to achieve, good success with your knee rehab. If you are only doing exercise, you may not get fully to a successful rehab. If you are, skipping your physical therapy altogether, if you are doing nothing, you are not. If you do not work to get back your knee range of motion, your knee is going to tighten up, and you're going to have significant difficulties and likely not have a surgical manipulation to improve that, you're likely going to have another knee replacement down the road, probably a year or two later. So I don't say that to scare anyone or anything like that. I'm just telling you the reality of having had a knee replacement. That is what you're looking at. So those are my thoughts on shoving on your knee and why a physical therapist should keep that tool in the toolbox if at all possible. So I hope that's been beneficial for you, and that maybe that's giving you a little bit of guidance on what your physical therapist should and maybe preferably should not be doing with you in your upcoming physical therapy sessions with them. Hopefully, Lord willing, you never have to get into a situation where your physical therapist is even considering doing that with you. But yeah, so we'll be saying prayers for you that is the case. So if you like this video, if this was informational to you, please give us a thumbs up button. Share this video out to any of your family and friends. And if you haven't already, do subscribe by clicking on that subscribe button, and we'll catch y'all next time. Later.